Good evening, everybody. I'm Rachel Sachs, Senior Director of Education and Programs at Cancer Support Community. Welcome to our live webinar this evening. For those of you joining us for the first time, let me tell you a little bit about the Cancer Support Community. For more than 40 years, we at the Cancer Support Community have been a relentless ally for anyone impacted by cancer. We help individuals manage the realities of this disruptive disease and get back to normal. Whether accessing our free services in person or at one of our nearly 200 locations online or via our toll-free helpline, you're getting a team of licensed professionals providing patient navigation, financial counseling, genetic counseling, pediatric support, and much more. This evening, we're going to discuss the upcoming changes to Medicare D coverage. We have partnered with OncoLink to bring you this webinar to better understand how the M3P payment options aim to help Medicare beneficiaries manage their out-of-pocket costs and make healthcare more accessible, equitable, and affordable. I'm extremely grateful to have with us today two expert oncology financial navigators to help walk us through and better understand how the Medicare prescription plan changes can impact our lives. We are joined this evening with Christina Bach and Amy Hoke. Christina is an advanced practice board certified clinical oncology social worker with over 25 years of experience in inpatient, outpatient, and patient education settings. Christina received her master's degrees in social work and bioethics from the University of Pennsylvania. She is currently the psychosocial content editor for OncoLink.org. She has expertise in financial toxicity, insurance and public benefits, trauma-informed care, medical ethics, social media, and animal-assisted therapy. Christina is a field liaison at the Bryn Mawr College Graduate School of Social Work and Social Research and a financial navigator specialist for the Cancer Support Community Helpline. Christina is also the chair of the Board of Oncology Social Work Certification. Welcome, Christina. Amy is a master's level social worker with 20 plus years of experience in both healthcare and behavioral health. Her practice is focused in oncology, specifically addressing financial toxicity. Amy earned her MSW from Fordham University Lincoln Center and is a certified oncology social worker. Amy is a financial navigator for the Cancer Support Community and a financial navigator for the cancer program at Grandview Health, where she created and implemented the financial navigation program in 2018. Amy is an active member of the Association of Cancer Care Centers Financial Advocacy Network Advisory Committee, Initiatives Task Force, and has been recognized as a fellow for the organization. She is a member of the Medical Advisory Board at Living Beyond Breast Cancer. Amy is also a member of the Pennsylvania Cancer Coalition and their Quality of Life and Survivorship Work Group. Welcome to both of you, and we can't wait to hear from you.
Thank you so much, Rachel, for that lovely introduction. It's so great to be here with everyone tonight, and I did recognize so many friendly names in the participants list, and it's wonderful to see you all here. Again, I'm Christina, and I'm here with my partner in so many things, Amy Hoke, who I am so incredibly honored to work with in the financial navigation space. She's been an incredibly important person for me to just run ideas by and have support because this work is really difficult, as I'm sure you all know. So we're really excited to be here, and neither one of us have any financial relationships to disclose to you before we get started tonight. Okay.
I'm Amy Hoke, and Christina, I want to thank you for joining us tonight. We really want to kick off with a poll to start the webinar. The first one, we'd really love to know who's in our audience tonight. So the poll is, who is in this audience? A, I'm a patient. I'm a family member, caregiver. C, patient caregiver duo. D, I'm a healthcare professional. And E, I'm here for more information. This is great. We're getting some results in. Thank you so much for participating. We have quite a few healthcare professionals, some here for information, quite a few patients, and family members and caregivers. Wonderful.
That's really exciting. Thank you all for participating. We do have one more. I guess we can, here are we sharing? Yes, sorry. Still learning the Zoom polls. So we're going to go to question number 2. How much do you know about the changes coming to Medicare Part D in 2025? So A, there are changes I didn't know. B, a little bit, not sure how they might impact me. C, I know some things and have some questions. Or D, I'm feeling very comfortable with the upcoming changes. Okay, great. Wonderful. So this is really fascinating information that just a couple of you said you're very comfortable with the changes. And a lot of you really seem to be here like, oh my goodness, I didn't know there were changes. I don't know how they're going to impact me. So let me reassure you, you are in the right place for some learning this evening. And hopefully we're going to demystify this a little bit for you. All right, so let's dive into our content. Just a little overview of the things that we're going to talk about tonight. We'll spend just a couple of minutes doing a little overview of Part D, what it is, the impact on the Inflation Reduction Act, called the IRA, on Medicare Part D. So we'll talk a little bit about the history of the IRA, the timeline for how some of these changes are being put into place, and really focus a lot of this time on the two big things that are coming for 2025, our $2,000 cap and the Medicare Prescription Payment Plan, also known as M3P. Then we'll spend some time really unpacking some things that you may want to consider before you make the decision to opt in to M3P. So that could be something called LIS, or the Low Income Subsidy or Extra Help. PAP programs, which is prescription assistance programs, where you get free drug from a manufacturer, copay foundation assistance programs, and finally state-based prescription drug assistance programs, or SPAPs. And we'll wrap everything up with some resources for more information and some times for Q&A as well. So let's start with some Medicare Part D basics. Sorry, I'm trying to operate like 4 different screens and 3 different slides. So bear with me if there's a little bit of delay. So Part D is Medicare prescription drug coverage. It actually was passed as a law into law in 2003, but didn't go into effect until 2006. So I can remember a time practicing social work before Medicare Part D actually existed. With Medicare Part D, it can be a standalone plan that you purchase in addition to a gap plan or your Part B, or it can be packaged together, bundled together with a Medicare Advantage plan. Part D is optional. You do not have to opt into it. And I have talked to a lot of people who say they're turning 65. I'm really on a couple of drugs or not too much, so I'm not going to opt into it now. Why should I? And I just want to caution that train of thought, because you may have late enrollment penalties if you don't sign up for coverage when you're first eligible, or if you don't have what's called creditable coverage, meaning maybe you're still working when you turn 65 and you have coverage through an employer. But if you don't, you might be eligible or have to pay late enrollment penalties. And while the penalties on the surface don't sound like a lot of money, the penalties are for the rest of your life, not just for the amount of time you didn't have coverage and could have, but for the rest of your life. So I always say people to think before you don't enroll. And to be honest, the Part D coverage has evolved a great deal over time. The first changes to Part D really started in 2014 as part of the Affordable Care Act, or the ACA, or Obamacare. And it was really supposed to be focused on a closing of the proverbial donut hole, which, if you've been on Part D, you've definitely heard the donut hole. That sort of worked, and it sort of didn't. The big issue was, and I know a lot of you on this call have experienced this, as cancer care has evolved into a space where more treatments are being delivered through oral medications, the coverage became more challenging for people on oral cancer drugs. And the prices kept going up, and many of you were in a catastrophic phase. So, in the donut hole, out of the donut hole, and into catastrophic within 2 months of the beginning of the year, and paying hundreds of dollars, if not thousands of dollars per month for your drugs. The Inflation Reduction Act really was a watershed moment and change for Part D, and brought about a lot of changes that are really, really quite exciting, and what we're really thrilled to be able to talk to you about tonight. So Amy's going to talk more about the impact of the Inflation Reduction Act on Medicare Part D.
Great. Thank you so much, Christina. We mentioned changes to Part D. Let's talk about why these changes are happening. The Inflation Reduction Act was signed into law in 2022 and includes several provisions that affect Medicare Part D. Let's look at some of these changes in the past 2 years and those that are coming up in 2025. So in 2023, some vaccines became free for Medicare beneficiaries, and Medicare covered insulin products were capped at $35 per month. This brings us to 2024. A program known as the Low Income Subsidy or Extra Help was expanded, which we'll talk about a little bit more later. And the 5% coinsurance in the catastrophic coverage phase was eliminated. There are many parts of this new law, including drug negotiations, but for the purposes of this webinar, we are going to focus on the expansion of extra help in 2024 and the upcoming changes in 2025, which are the $2,000 cap and the Medicare Prescription Payment Plan. So first up, the $2,000 cap. Starting in 2025, all Medicare Part D plans will include a $2,000 cap on what you pay for out-of-pocket prescription drugs covered by your plan. That is key information. They must be drugs that are covered even a little bit by your plan. This includes standalone Part D plans, as Christina mentioned, and those that may be bundled into your Medicare plan. So this $2,000 cap includes your deductible and your copays and cannot be more than $2,000. You will be covered at 100% after you spend $2,000. So for example, if your drug cost exceeds $2,000 in February, you're covered at 100% for the rest of the year. Even if, say, you start a new drug in May, you've hit your $2,000 out of pocket, and again, you're covered for 100% for the rest of the year. It also brings no more monthly catastrophic phase payments. This does not include your monthly premium. This is really important too. So you're always paying your monthly premium, if there is one, separate, paying for your plan. But this $2,000 cap does not include those payments. This does not apply to Part B covered drugs. It only applies to Part D covered drugs. And like other Medicare expenses, this cap may go up in the coming years. So there may be individuals out there and on this webinar that will not reach this cap because their drug costs are low. But for example, if you pay $10 per month, totaling $120 for the year, you might not reach the cap, but this cap will lead to thousands of dollars in savings for Medicare beneficiaries that take high-cost drugs. And prior to the upcoming cap, many individuals are and were paying much more. So even though we can look forward to this cap, $2,000 can be a financial burden for some. Now I'm going to turn it over to Christina to talk about the 2025 change, the next one, the Medicare Prescription Payment Plan.
So as Amy was saying, that $2,000 before this prescription drug plan payment plan went into place, I know many of you are probably familiar with, would all have been due in the first month of the year. And it really was causing a great deal of distress for folks who were having to put out large amounts of money very early in the year, especially right after the holidays. And maybe if they're in a Medicare Advantage plan, their annual maximum out of pocket had also just reset. So, one of the things that the IRA also did was create something called M3P, Medicare Prescription Payment Plan, or it's also being called the smoothing, which I just think is a little weird, but we'll go with it. What it allows you to do if you have Part D is to smooth or spread out the cost of your covered medications over the course of the year. So that $2,000 will not all be due in January if you opt into M3P. It must be offered by every Medicare Part D plan, and it is voluntary. So you have to opt in, and you have to opt in every year that you want to be in it. So if you opt in for 2025, that's great. For if you want to opt in again for 2026, you will have to do it again. It won't just carry over. You could also decide that you want to opt in now during open enrollment for your smoothing to start January 1. Or perhaps you're not on any medications now, but you go onto an expensive medication in April. You can opt into the program in April as well. And this can really help you plan and budget within your income. So the M3P may help, again, if you are on expensive medications or if you have to pay a lot for your medication in a short period of time. It also, if you're just the kind of person that likes a set kind of payment over a course of time, it also may appeal to you as well. But again, it's really a personal decision to weigh if you think that this might be something that you would want to opt into.
So we want to point out some options. If you're deciding whether or not the M3P would benefit you or not, we want to point out some places you can go for help. So you might want to ask for help someone at your treatment facility if there's a financial navigator or a social worker that can give you more information about the cap, the M3P, and whether or not it's a fit for you. If you don't have somebody at your treatment facility to talk to, you can reach out to the Cancer Support Community helpline at the number on the screen, and we can help direct you from there. I really wanted to spend some time on some tools that Medicare has made available that can be really helpful. So the first one is the Medicare.gov M3P tool. This will give you kind of a general idea. There are some questions. It'll give you a general idea if the M3P is a good fit for you or can be helpful to you. The next one is a little more detailed on Medicare.gov. You go to the plan finder where you go to look at plans during open enrollment, and this will give you more of a detailed look based on your drugs, your pharmacy, your area, your plan, and gives you the option to look at the M3P and your costs with the tool, with the M3P payment plan, and without. And then you also can call Medicare at 1-800-Medicare and talk to someone there to help guide you and see if the M3P is something that would benefit you. And finally, we really like to share about SHIP counselors. This is a program that is in every state, in every county, where you can access an unbiased, highly trained volunteer Medicare counselor that can help. And you can find out where your specific SHIP program is by calling this number. So now we're going to go over these tools on the Medicare website in a little more detail. So the first one I mentioned is the general one, and if you're wondering, should I opt in or not, you want to do your research. So that this was the first one that I mentioned. It's right on the Medicare.gov website. It's under What's the Medicare Prescription Payment Plan? And at the bottom of this screen, you'll see a question.
I don't think we have, or do we have that on the next slide?
Yes.
Oops.
There we go.
Sorry.
There we go. So there's a question at the bottom, will this payment option help me? So you click on there, answer a few questions, and again, this is giving you a general idea if the payment plan will help you. So I'm going to hand it over to Christina. The next tool will give you a little more detail about your costs, and Christina will talk about that.
And just an FYI, I did put the links to these direct tools that Amy discussed, the prescription payment. So this page, sorry, I clicked too quickly again. This page, as well as the next page we're going to talk to, I put those links into the chat box directly for you as well. So also, I think this is one thing our government actually does a really good job at is the Medicare.gov plan finder for cost estimates. So what you would do again is go to Medicare.gov and you're going to look on the website for this space right here that says health and drug plans. You'll hover over that and it'll give you these three options. You want to choose find health and drug plans. So we're going to look at a case example now of Pete. Pete put into the Medicare.gov the medications that Pete is on, and this was able to generate that Pete's annual yearly drug costs was going to be around $180, which is pretty low considering that he is on 8 different medications. And also, I just think a very interesting way to kind of know what are the ones that might cost us money. So you can put your drugs into Medicare.gov and see exactly what the cost estimates are going to be for the plan for the following year. Down below it, it says find out what your drug costs might look like with this payment option. That if you were to opt in to the Medicare prescription payment plan. Well, if we look at Pete's, without this payment option, Pete would be paying about $15 a month for all of the medications that he's on for a total of that $180. But if he opted into the Medicare prescription payment plan, you can see that there is a great deal of variability to the monthly payments. So the first month in January, it's $15, but the next month it might be $1, and later in the year it might be $45.29. Now, we could probably spend another 4 hours on a webinar explaining to you how the government has come up with the math. It's very challenging. I'm trusting the tools that they have made available to really outline what the costs might look like. And you would think, well, if it's going to be 180, why wouldn't it just be the same payment every month? I can't totally answer that question because I'm not sure I totally understand the formularies, but this is how they've come up with a plan like this. So just so you can see what that might look like, and you can use those tools again for free on the Medicare.gov website. So how do you opt in? So you decide, yes, I want to do this. You put all your drugs into Medicare.gov. I want to opt into this. You have to contact your plan directly. And I also just want to say, if you're considering changing plans for 2025, this is the time to do it. It is Medicare open enrollment. And it's really good time to put your list of drugs that you're on right now into Medicare.gov and make sure that all those drugs are still going to be covered by your plan next year and that you're choosing the plan that you want for next year. Once you do that, you can call the plan directly and tell them you want to enroll in M3P. The enrollment should take about 24 hours to become active. So this includes, say it's February 17th, and you take a bunch of prescriptions to the pharmacy to be filled, and they tell you it's going to be $1,200 tonight. And you say, oh no, that's a lot of money. And you decide you want to go home and opt into M3P. It will take about 24 hours for that to become active. And then once it does, you can go back to the pharmacy. It should show up in your plan information in the pharmacy computer that you're enrolled in M3P. And then your payments will be going directly to the plan. You will not give the pharmacy any money, and you will be billed directly from the plan. So let's look at another case example of Sue. Sue is on an expensive oral cancer medication. For next year, her deductible is going to be $590. She decides not to opt in to M3P, and in January, her medication is $2,000. So as of January, she has reached her cap and she'll be covered at 100% for the rest of the year. So just so you can visualize it, let's look at the calendar for 2025. Sue's making the decision that she's going to put all of her money out in January and have no drug cost for the rest of the year by not opting in to M3P. Let's look at a poll question now. Sue's oncologist changes her medication in July. What will the cost of this medication be? $0, $167, $500, or $2,000? Getting a lot of variety of answers. Thank you so much for participating. They're still coming in fast and furiously. Okay, so the answer to this question is 0. Again, you're not going to have a $2,000 cap for every medication. Once you've paid out that $2,000, which Sue had already done in January, even if she changes to a different drug in July, her copays for that, her out-of-pocket expense for that medication would be $0. Thanks all for sharing your answers. Okay, so let's look at Sue again. Same stuff. She's on an expensive oral cancer medication. Her Part D deductible is 20 in 2025 is $590, and she decides this time she's going to opt in to M3P beginning in January. So again, this is a direct screenshot right from Medicare.gov. This is exactly the kind of results that you can generate with your own information by putting it into Medicare.gov. Again, this is the option we just talked about. In January, she's paying $2,000 and her amount for the rest of the year, $0. If she opted into the payment option, as you can see, her payments would be $166.66 or 67 over the course of the next 12 months. So again, if you're the budgetary type and you like to know that this might be what your budget would look like every month, rather than putting that $2,000 out the beginning of January, this might really speak to you. So as you can see, here's her calendar there, and it looks a little different than before. Finally, we're going to get to Marco. Now, Marco's on 3 different kinds of medications, again, for 3 different conditions. And he's wondering about his options for paying for his meds in 2025 and wants to compare pharmacies he could use and to see if the payment plan might be a good option for him as well. So again, we put in his meds. He's on Eliquis, imatinib, also known as Gleevec, and metformin. And you can see if he gets it filled at his local CVS pharmacy, the drug cost would be around $11.76 for the Eliquis, $8.21 for the imatinib, and $0 for the metformin, for a total of $1997.89. But if Marco opted into using a mail order pharmacy, the cost of the Eliquis is much higher, but the imatinib is much lower. And again, the metformin is still $0. There's about a $10 difference between the two. I use this case example to highlight how important it is for you to be looking at all of your options for where you're getting your medications from. And I will say that something that happened yesterday, I was working with a client, and they may be on the call, so if you're here, hello. And the formulation of insulin that they are on, okay, you're thinking insulin, that's supposed to be $35. Correct. But the formulation that they were on with the current Medicare Part D plan that they are on is not on their formulary next year. And so it's not a covered drug. And the cost of it was over $2,500. So again, I'm just pointing out how important it is to look at the drugs, look at the formularies of what drugs are covered by your plan before you opt into it. And he was left with the decision of, do I stay with the drug plan that I'm on and that I know and take the formulary to my endocrinologist and have them put me on a different formulation of insulin that's covered by my plan? Or do I switch my plan to a different plan where this formulation of insulin is going to be covered? And again, yes, this is a lot of work. On top of the fact that you are dealing with and coping with cancer, it's really important to think about how is this going to fit in to all of the other things that I have to do as a patient. So this breaks down, again, if Marco were to go to his CVS, this is what his payments would look like without M3P. And this is what it would look like with M3P. And as you can see, again, there's great variability in the monthly payments that Marco would have to make with both the mail order pharmacy and the CVS pharmacy that he got at. So you can see, again, this is how different those monthly payments might look with or without and at two different pharmacies.
So I opted in. How do I pay for my drugs? So let's talk about how you now pay for your drugs. Remember, M3P does not lower your prescription drug costs. It only allows you to pay over time. So you will not be paying at the pharmacy. If you opted in, you'll be billed from your plan for your monthly drug costs. And some of those examples are what Christina just went over in some of the case studies. And this bill is separate from your monthly plan premium. So we want to make sure that you know that that bill is separate. You're still paying for your premium, and then also paying your monthly bill that you're getting from your plan each month. I want to mention that if you opt out, you aren't expected to pay a lump sum, but your plan will still continue to bill you monthly. You can choose to pay the lump sum or continue the payments. So that's if you were opted in and then after a couple of months decided to opt out, you have the option to pay the lump sum or, like I said, keep with those payment plans for those drugs that you are on the payment plan for. But if you opt out and you have a new prescription drug going forward, you will have to pay for that new drug cost at the pharmacy. So Christina's now going to talk a little bit about missed payments.
So this is definitely something that people are like, oh, what if I can't make my payment or I miss my payment? We all have had those months, I'm sure. The plan is required to issue you a notice of missed payment. And you do have a 2-month grace period. And unlike things like credit cards or layaways or things like that, there's no interest or late fees if you do miss a payment. However, if after that 2-month grace period you haven't made a payment, you will receive a termination notice of your M3P enrollment and a balance will be due. But I do want to just really highlight that the only thing you're losing is M3P. You're not losing your Medicare Part D coverage as long as you're continuing to pay your Part D premiums. The only thing that could happen is they're going to say you can't be on M3P anymore because the payments haven't been made.
We want to pause right now for a couple of special considerations that you may want to look at as resources as you now know about the $2,000 cap and wondering if opting into the M3P is beneficial to you or not, or if you need to. So we're going to go and look at those special considerations. They include the low-income subsidy program or extra help that I mentioned prior, foundation copay assistance programs, patient assistance programs, and state pharmaceutical programs. But quick, we have another poll real quick that we'd like to do. How many of you have heard of the extra help or low income subsidy? A, no, and want to know more. B, yes, but I'm not sure if I'm eligible. C, yes, and I'm on this program right now. So if you could take a minute to take that poll, that would be great. Thank you so much. So we have some of the answers coming in. Thank you. The majority do not know about it. We're going to tell you some information about it. We're happy that we have that information, and we kind of suspected that they have heard about it and not sure if they're eligible. So we're going to go over that. And yes, a few are on the program right now. Thank you so much for taking this poll. Switching screens a little bit here. So the first thing is, earlier I mentioned that in 2024, the low income subsidy, otherwise known as LIS or extra help, was expanded as a provision under the Inflation Reduction Act. This program can help pay for premiums, deductibles, and co-insurance for Part D. If eligible, it can lower your prescription drug costs up to $4.50 for generics and up to $11.20 for brand drugs. These are the 2024 guidelines. We don't have the 2025 information yet. In order to qualify, you can see on the screen that there's income information and resource limits for both individuals monthly and annually, and married couples, again, monthly and per year, and the resource limit. You can also see at the bottom what is counted as resources. This information is all on the Medicare.gov website. This is really an important program, and like I said, can help with prescription drug costs, deductibles, and premiums for Part D. So this may be an option for some, and if eligible, can help you decide if you need to opt into or want to opt into the M3P or not. Last year, I remember Medicare estimated that there were close to 3 million individuals that could benefit from this program, but were not currently enrolled. So let's go over how to apply. So you can apply at any time before or after you enroll in Part D. You can apply by going online to the Social Security Administration website at ssa.gov or by calling Social Security at 1-800-772-1213. And when you call, you can ask for an appointment to be set up, to make an appointment and meet with someone who can assist you with the application, or you can ask them to send you a paper application. After applying, you'll be notified in general in about 3 to 4 weeks whether or not you've been approved or denied for LIS or extra help. So the next resource that we want to talk about are copay assistance foundations. This is a resource that can help with a $2,000 out-of-pocket cost if one is available. So copay assistance foundations are third-party charitable foundations that provide financial assistance to assist with your out-of-pocket expenses. You must meet eligibility criteria. They're based on income, diagnosis, and some are also specify specific medication that you're on. They are available for 12 months, but re-enrollment or ongoing availability is not always guaranteed. They generally work on a use it or lose it process. So you want to be aware of the windows to submit your claims. And generally, your treatment facility is helping with this, or your pharmacy, and they are billing the claims for your treatment using these copay assistance foundation. So the first thing you want to do is see if the copay foundation is available based on your diagnosis. That's always the starting point. Their availability varies, but if you find that an appropriate fund is currently closed, some also have wait lists. It's also good to keep checking the website or calling the foundation to see if the fund is open. And the staff at your treatment facility or pharmacy, including specialty pharmacies, are usually very familiar with these foundations. So you could always reach out for help getting to know what foundations might be available to you, if any are open. And they're also generally involved with putting in the claims for your treatment costs. So let's look at a few key considerations with copay assistance foundations. So if you currently have a foundation in your current year and want to see if it carries over into January to help meet that $2,000 out of pocket for the year, I you might be able to do that. There are many factors involved in that, whether or not you have enough funds for this year, if your fund is still open, what your claim window is, and if you'll have enough to carry over for January. I want to emphasize how important it is to work closely with the staff at your treatment facility on this, or your pharmacist, to find out how much is left, how much is needed for all current treatment in 2024, and if there will be funds available from the same grant going into next year. But let's say you don't currently have a foundation, and in January you opt into the M3P, and one becomes available to you later on. So maybe in February or even March, you can use that foundation to help meet your out-of-pocket costs instead of staying on the monthly payment plan. So again, one becomes available, you've been opted in, you might have paid a few of the M3P payments to your health plan, but now the fund becomes available, you apply, you've been approved, you can then use it and meet that $2,000 out-of-pocket cap for the year. We want to discuss real quickly a recent question that we've had. People have been asking if foundation funding will be impacted by the changes that have been happening and are upcoming for Medicare, and we have not gotten any information about that or heard that there are any changes to foundation funding. So the next resource we'd like to highlight are patient assistance programs. These are programs that through drug manufacturers, also known as free drug programs. And this may also be a resource to help you with the out-of-pocket of high-cost drugs if you qualify. They are available for some drugs and not for all, so you need to check that first. The criteria and eligibility depends on rules established by the manufacturer. So it can be based on income and other requirements that they have established. And each program could be a little bit different. We also want to point out that there may be some folks who are currently using a patient assistance program for 2024 and have been notified of changes to the program eligibility for 2025 through the re-enrollment process. So every year when someone is on a patient assistance program or PAP, they have to re-enroll at the end of the year for the upcoming year. And you might have noticed that either there are some changes or are not. So each manufacturer is a little different, but you will be noted of that through the re-enrollment process. So some of the changes we're hearing about can be related to income eligibility, applying for and being denied for LIS or extra help, opting into the M3P and the payments are unaffordable, and proof that a foundation that I just talked about is not available. So again, you'll go through the annual normal re-enrollment process as you always do, and we'll know if you no longer qualify. We just wanted to point this out. You may continue to qualify, but if there are any changes and you no longer qualify, it's something you can anticipate any changes to your eligibility ahead of time. And now by knowing the upcoming $2,000 cap and that the Medicare Prescription Payment Plan is available, that could be helpful. And you can also check the other resources that I just mentioned. So I am going to turn this over to Christina to talk about the state pharmaceutical assistance programs.
Thanks, Amy. So just really quickly, wanted to highlight all of the states here that are in this really beautiful, vibrant teal color have extra pharmaceutical assistance programs, SPAPs, for either the aged or i.e. folks that are on Medicare, and in some states that also covers folks that are on Medicare due to disability. So in Pennsylvania, we have something called the PACE program, as well as PACENet, funded by the Pennsylvania Lottery. Those two programs help the folks who are over the age of 65 with the cost of their prescription drugs. And this is in addition to all the other things. And honestly, if you're eligible for PACE or PACENet, I think, again, like the LIS, this is one of the most underused resources in the state of Pennsylvania in particular. Obviously, that's where we're coming from, so I can speak with that lens. In New Jersey, same thing, and just worked with a friend of mine and her mom to get her on New Jersey PAD, which was a similar program that offers much lower cost medications, but the income allowances are higher than that 150% for the FPL. So if you live in a state where an SPAP is available, this also might be something that you want to investigate to help lower your drug costs. And I'll be sharing a link in the website as well, or in the chat as well, that takes you to a listing of all of the state pharmaceutical assistance programs that we've listed here. You'll see that many states also offer something called ADAP, ADAP, which is the Age Drug Assistance Program, and that is for people with HIV and AIDS to cover the cost of their HIV medications. So if I were to put all of the ADAP states on, almost every state in the country offers an ADAP or an SPAP program. But I really wanted to highlight the SPAP program for the purposes of this webinar. I think it's a great, if you, again, live in any of these states, it's definitely something that you might want to look into to help reduce the cost of your prescription drugs. So what are some key takeaways? Amy, we did so good on time. I'm really proud of us. Again, number one, you can opt into M3P during open enrollment for those changes to take effect in 1/1 of 25. You're still unmuting.
Oh, thank you. You can opt in or opt out at any time during the year.
Be sure to check your eligibility for LIS or extra help before you opt in. Again, just want to highlight what Amy said. 3 million people estimated that could be on LIS that are not. And it is truly a transformative, amazing program that we really should be getting more folks to that are eligible.
Another takeaway is enrolling in M3P does not change your overall out-of-pocket responsibility for prescription drugs. You still have the $2,000 cap, so it doesn't change the overall responsibility, but it allows you to opt into a payment plan.
And that $2,000 cap is for 2025. This was actually news to me as Amy and I were researching this webinar. And like everything else, it may be adjusted for inflation in the future years. So I really love that $2,000 cap, but just be aware that next year it may be 2,500. It might still be 2,000. Maybe it'll be 1,500. Who knows? But just be aware that it's a good thing to check in every year of what that cap is going to be.
We cannot leave this webinar without mentioning open enrollment. Christina mentioned that if you want to opt into the M3P to start January 1st, you can do that during open enrollment or at any time next year when the M3P starts. open enrollment is also another great time. It is happening now until December 7th. This is a time for you to use tools like Medicare.gov to compare plans, drug costs, and M3P options.
All right. We're doing great. I'm
You-
so proud of us.
You're doing awesome, right on time. So everybody, thanks for joining us. We're going to get to questions. We are going to drop a poll about your experience with the webinar. So please feel free before the end of the webinar to answer that poll. We would love it. It helps us inform how we proceed with webinars in the future. Okay, so there's a lot of questions, guys. So we'll get to as many as we possibly can. Can you ladies review what are Part B covered drugs?
You want me to take this one, Amy?
Or
She knows that I cheated and may have this because I knew this was going to come up. So there are some oral anti-cancer medications that are also available as an IV formulation. So they're both oral and IV. Those medications are covered under Part B, regardless of the formulation that you get. And there's a very specific list of them. It's capecitabine, which is also known as Xeloda, cyclophosphamide, etoposide, melphalan, methotrexate, and temozolomide, which is Temodar. I cannot say drug names. I usually just say yabba dabba dumumab, and that usually gets me where I need to be. There are also some antiemetics for nausea and vomiting that are also covered under this same provision with Part B. I have absolutely had patients go to their pharmacy with a prescription, for example, for Xeloda, and have the pharmacy process it under Part D, only to have the claim denied because it is a Part B drug. So it's really important for cancer patients to understand that that specific list of drugs, and I will drop it in the chat when I get done talking, and I'll let Amy take the next question. If you get prescribed one of those oral medications that's also available as an IV, you definitely want to make sure that your pharmacy is processing that under Part B. And by the way, no, that drug does not count towards the $2,000 cap. It's a really important thing that's billed under Part B, and that's where you're going to be also. You may have a 20% copay for that medication. So that's where your gap plan, if you have a supplemental plan, would come into play. So I'm going to put the list of the medications in, and Rachel, if you want to get that next question to Amy.
Will do. My 65th birthday is in February. Open enrollment doesn't apply to new Medicare patients, correct?
right. So open enrollment is for those that are currently on a Medicare plan to look at other plans, to look at their prescription drug plans. However, outside of open enrollment, being that you will be eligible for Medicare in February, you can start the process for enrolling in Medicare and setting up Medicare 3 months prior to February, the month of February and 3 months after. But if you are anticipating of being Medicare eligible February, it starts February 1st, you can use this time to start setting up your Medicare.
Okay, thank you. Are specialty pharma providers' identity available on the Medicare website?
I have not seen them on the Medicare website. And even yesterday, I did put in the name of one of them. However, thank you so much for asking a question about specialty pharmacies, because just like the neighborhood CVS, all of the specialty pharmacies are required to accept M3P. And I think that one of the reasons that they're not listed on the Medicare.gov website, and again, I am just speculating, is because certain drugs have exclusive arrangements with certain specialty pharmacies. And so regardless of what your coverage is, it has to come from a distribution perspective from that specialty pharmacy. And oftentimes there's things going on behind the scene with plans and those specific distributors of those medications to be sure that they're covered by all of the plans that are available. Amy, do you have any other thoughts on that?
Yeah, it also could be because each plan may have a preferred specialty pharmacy that they would like you to use and for your provider to send the prescription to. So that may be another reason that they're not found on Medicare.gov because there may be a specific specialty pharmacy you need to use.
But
Or to,
one thing you can always do when you contact your plan is ask them, what specialty pharmacies do you work with? And that's a really important piece of knowledge to have as you're going into appointments, and maybe your doc needs to call you in a special drug.
Perfect. Okay, these are great questions.
Mhm.
Can the plan change the expected monthly price if the pharmaceutical company changes the price of the drug?
I think we're both thinking really hard about how to answer that.
yeah,
Because I also want to just make sure that we're level setting that you're never going to pay more than $2,000. But yes, do we know that things change over the course of a year? Yes. And I mean, even last year, I worked really hard with one of my clients to go through her whole list of drugs, only to have the drug plan change the formulary in January, which was very frustrating. So understanding that that is one of the spaces that, again, you can only take the snapshot of what you have right now, the medications that you are on now. And sadly, we don't have this crystal ball to know what we're going to need, know what the plan is going to change, and know how prices may change as well in the future. But the thing that I do like is that we do know you're not going to pay more than $2,000. Whereas in the past, if the price went up, you were paying more in that catastrophic phase because you were paying 25% of the cost. And we do know that that's going away.
yeah.
Okay, perfect. If your drug costs are less than $2,000 a year, should you enroll in Part D?
So I think there's two different pieces there. So the $2,000 per year is separate from enrolling in Part D. I'm wondering if the question is if you should enroll in the M3P, the payment plan. So we can break those up. So if you're like Christina gave the example of Pete, his costs for drugs were 180 per year. He decided not to enroll in the prescription payment plan, but I wasn't sure if it was Carol. There was um, another case that we looked at. Her prescription costs were at least $2,000 and capped at $2,000. And Christina gave an example of her not opting in and paying the $2,000 in January or opting in and spreading that throughout the year. So, but if you are more like Pete and your drug costs are low, you can look at what those costs will be and decide whether or not you want to pay for those drugs at the pharmacy, or if the amount is higher and you'd like to opt into the payment plan. But enrolling in Part D is separate. So that is your prescription drug coverage. And so when you become eligible for that, that would be a decision that you would be picking a Part D plan unless you had other credible coverage that you would be keeping. So I hope that I answered that correctly. I'm reading it as if you should opt into the prescription payment plan.
Yeah, I think that was very comprehensive, Amy. Thank you.
And I do just want to add one thing to that, Aim. Sorry, Rachel, is that
Mm-mm.
if you were talking about Part D, if your drug costs are low, I do think that is a very personal decision. And I always talk about, are you risk averse or risk tolerant? If you are risk tolerant, you might be like, I'm going to roll the dice. And if the penalty, I don't want to go on Part D. My drugs literally cost $3 a month. Why should, or I'm not on anything. So I'm just going to roll the dice. And if I need to, I can sign up later and I'll just deal with the penalties. I, Christina, am a risk averse person. So I'd rather be overinsured and have the coverage and not use it and know that if that rainy day comes and I need an expensive medication, I will have access to it. Also remember that, when you enroll in Part D may affect the cost of your premium as well. So it's a lot to sort of take in, but again, a very personal sort of decision to make about whether to opt in, especially like there's so many other spaces to get medications now, whether it's through generic drug programs at Target, at Walgreens, through the Mark Cuban Cost Plus Pharmacy, through using coupons through GoodRx. Yeah, that's great. Not a lot of that's available for cancer medication. So just putting that out there to everyone.
Thank
Okay.
you, Christina. That's great.
Have you heard anything about Revlimid not being covered on formularies in 2025? And also, have you heard anything about running out of lenalidomide due
Same
to
drug.
restrictions the manufacturer put on amount of generics available?
Amy, do you want me to take this one? Because
Sure.
yeah. So I know this drug is obviously something for MDS and myeloma, and I'm sure one of my lovely myeloma group members might have asked that question. I'll anticipate we'll talk more about it in our group in a couple of weeks. I've done some research already in plans. I am not seeing Revlimid not being covered by at least one plan. And quite frankly, yesterday I looked at 23 different plans and it was covered under all of them. Now, where we run into difficulty is this push and pull between the manufacturer of the brand name and the generic medication. And honestly, I'm not quite sure what is happening in that space, but I did talk to somebody yesterday who the brand was not available, and then they wanted to get the generic or vice versa. And it was an issue at the pharmacy, but the pharmacy was really able to work on getting the patient the drug. So I haven't heard of a shortage either. It is not coming up on my shortage list. So, and there's lots of drugs that we have shortages on now. So I think that you will still have access to it. It just might take a little bit more work. And remember, for those of you on the call who have myeloma, there's still a lot of copay assistance out there to assist with the cost of Revlimid. And again, just going to drive this home one more time. You're not going to pay more than $2,000 next year for Revlimid, which I know is so hard to get your head wrapped around because you've been paying so much for it for so long. But I promise you, you're not going to pay more than $2,000 for it next year.
Okay. I know we're at time. Do you ladies have time for two more questions?
Sure.
Okay. And if your questions weren't answered, don't forget to call our helpline where we have many experts that can answer your questions, and you might just get Amy or Christina as well. Okay. Part B would also cover infusions in a cancer center, correct? i.e. immunotherapies?
Yes, Christina, I can take this one.
Mhm.
So yes, Part B does cover infusions in the cancer center, including immunotherapy.
Okay. Do you recommend mail-in pharmacies to lower costs?
Again, I think that's going to be a case by case basis. And I also just, from a practical standpoint, be sure that you can actually get your drugs when they're mailed to you. I mean, I live in a city, we have a lot of problems with porch pirates. And so I always caution people, if they're going to be using a mail order pharmacy, that they're able to receive the drugs when they arrive, because a lot of times there can be delays if your medication just happens to get feet and walk away. But again, thinking back to Marco, the case example that we gave, there was some obvious differences to how the drugs were priced. But again, ultimately, he was on the same drugs and it was always going to cost him just about $2,000. Again, it was like a $10 difference. That being said, I think it's really worthwhile for you to use the plan tools. And again, use resources like the Cancer Support Community Helpline if you need help, because I understand sort of the technological aspects of feeling a little overwhelmed by those websites, and Amy and myself, ship counselors, we're really, really good at navigating those sites. So if you need help, please never be embarrassed to ask for help with navigating some of this technology, because I know that it can be really frustrating. But I do really feel like this is a lot of good information that's out there and readily available. And we really just want you to get you to good, reliable information that can help you make decisions.
And
Awesome.
Christina, if I can add, you had mentioned ship counselors again. We mentioned it during the webinar. The person that had asked about starting Medicare in February, a ship counselor can be an amazing resource for you to get an full education on all different options for Medicare. So we do actually have those resources on a slide, and Christina did put those in the chat, or is going to be.
I did put them in the
There
chat.
they
And then this is again just the phone numbers of these great spaces to go to. And I do just need to put in a plug for my full-time employer and our partner here for this webinar tonight. I do work for OncoLink.org, and OncoLink is a free cancer education website that is based at the University of Pennsylvania. And I have a ton of information on the website that is available free of charge to anybody who needs it, including an entire series of webinars that are available for you to watch that really unpack all of the different parts of Medicare. I'm going to be updating the Part D one. I haven't done it yet because I've been making TikTok videos, but you can also follow us on TikTok too if you want to see a little bit of shorter videos. But we have a lot of great information there available. Just if you are an information seeker like I am, it's a great way for you to get informed and really be prepared for if you go to a ship counselor, these are the questions I have. If you call to the helpline, these are the questions I have about my coverage.
Okay, one last question, but I just want to note two things. One, several comments about how amazing you ladies are and how amazing this webinar was. And there is no fee to calling our helpline. It is completely free and you will talk to a specialist. So please feel free to call us. One last important question. How do patients opt in for the M3P? I was told by a patient that their Part D plan company, I'm not going to say who that was, didn't seem to know what they were talking about when they called to try to sign up late last week.
Okay.
Wow, I'm not
Yeah,
surprised.
that's so if you are you do call your plan to opt in. So that was correct. And we mentioned that earlier. You call your plan directly. You can opt in right now. So open enrollment started on October 15th and goes through December 7th. And I'm just wondering if that particular staff person didn't know that you can opt in now. It doesn't start until January 1, but you can do that now. So if you found that, or if anyone else has called their plan and wants to opt in now, so it starts January 1st, ask to speak to someone else. So you can, like I said, opt in from now until December 7th, or any time next year, starting on, I guess, the 2nd, right, when they're open again, you can call and opt in. But you did the right thing by calling your plan. If you're not getting help, please ask to speak to someone else.
Mhm.
Okay.
I oftentimes will find just hang up and say, I'm going to call someone back, or I'd like to speak to the manager. It is okay to be, I'd like to speak to the manager person when it comes to this stuff. And I am actually not surprised to hear that, because I do think that the unrolling of this has been a little messy. And I'm still a little bit concerned about how it's going to look come January 1. So hold tight and know that there's lots of folks out there that are really working behind the scenes to advocate for the patient experience in accessing this program and accessing their assistance, and just be persistent as well with your plan. I think that's also important too.
Perfect way to end. Thank you, ladies. Thanks to Amy and Christina for joining us tonight for this important webinar. Thank you so much to our sponsor, Takeda, and partner, OncoLink, for their generous support of this event. This event has been recorded and will be made available on CSC's webpage that is posted in the chat. Thank you again for your attention. Happy holidays coming up. We wish you peace and health. Have a good evening.
Everybody.